Okay, I'm back for part two. We're going to get at now into more of the clinical aspect of the syndromes for strokes. And so let me go ahead and share my screen and then make it a presentation. There we go. All right, so we're going to pick up right where we left off. And so the syndromes, if we can start to understand the syndromes, we'll understand the signs and symptoms our patients may or may not present with. Now remember, neuro is gray, so you might think that they're going to present one way and you go in and things look a little bit different, but it might be because the stroke extended, there was a herniation, there was midline shift, those types of things. So if we think about these syndromes for internal carotid artery, so if their internal carotid becomes occluded, then they will present because the two branches off the ICA are going to be the ACA and the MCA. So they're going to have contralateral upper and lower body involvement. And so that's kind of up a creek without a paddle, but these patients still do resolve and they end up okay. Vertebral basal artery syndrome, you look at all the different branches that it could be, and we're going to go through each one of these as we get through here. So ICA, I'm not going to keep going back to this anatomy side of things, but I want you to just remember the ICA. There's typically massive edema, brain herniation. I had one patient, he was an Air Force soldier who was lifting a box and blew out his ICA. So he had a history of hypertension, all sorts of things. And so his name was George. I can still remember him. And he actually did really, really well. And now he ambulates without any assistive device, but an AFO. Didn't get much arm back, but he is functional. ACA supplies the 2/3 of the medial cerebral cortex. As we talked about, more lower extremity if we look at the motor homunculus. And so upper extremity is usually more spared in these patients. And so I put all of these in here for you as little boxes to help you kind of orient. You have a couple resources. You have the neuroscience, Lindy Ekman is going to have some great charts for this, as well as your Red O'Sullivan book has some really good charts as well about different types of syndromes. So if we look here, signs and symptoms, contralateral hemiparesis involving mainly the lower extremity, hemisensory loss involving mainly the lower extremity, incontinence, problems with imitation by manual tasks, apraxia, so poor motor planning. They may have a slowness, delay, lack of spontaneity, contralateral grasp reflex, and can be symptomatic if circle of Willis is competent, so asymptomatic. So if they have anastomoses for different blood supplies. So that's your common clinical presentation. I would actually urge you to start concept mapping this. And I know you're probably sick of me saying that. Middle cerebral artery. So this is the most common site. Lower extremity is usually more spared. So these patients are typically a little bit more increased incidence of ambulatory because of that. And so here's another great signs and symptoms table. And so they're also going to have contralateral hemiparesis, hemisensory loss, motor and speech impairment with the MCA is highly likely. So Broca's or non-fluent aphasia, receptive speech, so it could be either receptive or expressive. They're going to have perceptual deficits, neglect, deperception, spatial awareness, agnosia. They also are going to have motor planning issues. They may also have the homonymous hemianopsia, meaning that they've got visual field cuts, loss of conjugate gaze to the opposite side. They may have ataxia as well, but more sensory. And they may, if they've got pure motor hemiplegia, then it's typically more of the lacunar infarct. And so from Lindy Ekman, here you go. There's another table that's going to let you know if it's a left hemisphere versus a right hemisphere. So remember I said right sides tend to be impulsive, left is more hesitant. So if you have a left hemisphere stroke, you're typically going to have more language or speech disorders, difficulty understanding, dysarthria, cautious behavior, hesitant to try new tasks versus right hemisphere stroke. They're going to maybe have the incidence of left neglect, impulsive, unaware of their problems, may walk without necessary cane or brace, so they're just going to be unsafe. They're typically the fall risk. They also, because language is typically intact, people may think that person is much more capable than they actually are. So here's another great chart from Lindy Ekman if you like to look at things and how they're different. So please, please, please use these charts and make concept maps for you to understand the neuroanatomy and then the presentation. So remember, if we look at the brain structure and we look at the areas where some of the incidents of some of the common impairments are, it makes sense based on the distribution. And then if we look internally, so if we have a transection, then we can see the other options as well. And so vertebral basilar artery syndromes, these, if we look at all the branches, you could have the vertebral artery, the basilar artery, and then of each ones that it actually supplies. So you can see all of this here, and then the basilar artery, and then the posterior cerebral artery. And so if we think about this, we're going to get into the different syndromes. Syndromes include medial medullary, lateral medullary, basilar, medial inferior pontine, lateral inferior, and then PCA. Guys, just think vertebral basilar artery because it's the posterior blood supply, brainstem signs and symptoms, and typically ataxia coordination dysfunction. And we're going to go through to make this more clear. So medial medullary syndrome, you're going to have ipsilateral to the lesion, same side of the lesion, because if you think back where things cross, paralysis of half the tongue, contralateral to the lesion, they may have some hemiplegia in the upper and lower extremity and impaired sensation. So if we look up here, we've got cranial nerve 12 involvement, hypoglossal, and then contralateral because of the corticospinal, and then we've got the medial lemniscus, dorsal column medial lemniscus. So you have to know your anatomy to understand the presentation. Lateral medullary syndrome. So this is also called Wallenberg syndrome, occlusion of the vertebral artery posterior inferior cerebellar or basilar artery. So cerebellar, what are you automatically going to think? Ataxia, correct? But same side of the lesion, cerebellar symptoms, loss of pain and temperature of the face, sensory loss of the upper extremity, trunk, or lower. On the opposite side of the lesion, they may have pain, dysfunction, or temperature to the face. You may also see Horner syndrome. And so if we look over here, we've got ataxia, loss of pain and temperature secondary to cranial nerve 5, vertigo because of the vestibular nucleus, and nystagmus. So these patients are dizzy, and they're the most commonly missed diagnosis in the ER because somebody thinks it's the inner ear, not the brain, so they miss this type of stroke, and it actually can be devastating. What is Horner syndrome? It's meiosis, ptosis, meaning ptosis is the inability to open the eye, so it's a droopy eyelid, and decreased ability to sweat. So if we look at this, dysphagia, dysphonia, so cranial nerve 9, 10, so diminished gag reflex, laryngeal muscles, sensory impairment, and then also spinal thalamic. So that's where some of this goes in. But the autonomic nervous system is actually involved as well. Basilar artery syndrome produces brainstem signs and symptoms and posterior cerebral artery symptoms. This is called locked-in syndrome. This is not favorable. So typically they end up completely paralyzed in all 4 extremities, which is called tetraplegia. They are unable to speak. They have lower bulbar paralysis, cranial nerves 5 through, we can look at 12. They have preserved consciousness, and the only thing that they can actually do is move their eyes for communication. I've seen 2 patients with this. And so if you think about it, you need a lot of technological assistive devices and adaptive devices, communication boards, and a lot of the time we'll actually look at some of this, but they actually use their eyes to communicate. So they have to establish. So they can't talk, they can't move. Cognition's fully intact, so they have all of that consciousness and they're locked into their own bodies. Medial inferior pontine syndrome is, look at this again, ataxia, nystagmus, conjugate gaze to the same side of the lesion, and double vision. Diplopia means double vision. That same side of the lesion, contralateral, hemiparesis, impaired sensation. Lateral inferior occlusion of the anterior inferior cerebellar artery. Look at here, ipsilateral, ataxia, nystagmus, vertigo, facial paralysis, deafness, impaired facial sensation, and contralateral, impaired pain and temperature. So it all goes back to your tracks of where things cross. So you need to go back and take a look at that. And so it wasn't just something you learned in neuroanatomy, neurophys, and then forgot. You actually have to go back and understand. PCA syndrome, posterior communicating arteries. So contralateral sensory loss, involuntary movement, so they may end up with tremor, transient contralateral hemiparesis, and homonymous hemianopsia as well. So if we look at PCA, and you look here, and I'll move myself so you can see it, it is that ventral, right? It's the back part of the brain right by the cerebellum. Cerebellar arterial occlusion, big things, right? Incoordination, ataxia, intention tremors. That should be very, very common for you to hear now. I'm hoping that that is starting to stick. And so if we look for PICA, posterior inferior cerebellar artery, we look ipsilateral, so we've got hypertonicity, hyperactive reflexes, and then we also had vertigo, nausea, and nystagmus. And so the anterior, or AICA, right, ipsilateral ataxia, hypotonicity, that's the big difference. If we go back, look, we've got hypertonicity for the PICA, and we've got hypotonicity for the AICA. Hyporeflexia, dysmetria, dysdiodocokinesia problems, movement decomposition, rebound phenomenon, now you know how to test for that, ataxic gait, intention tremor, and coordination. And they may also have vestibular signs, sensory impairment in the face, difficulty swallowing, speaking, as well as Bell's palsy. So if we have occlusion of arteries to the brainstem, look at this anterior spinal artery, vertebral artery, or basal arterial occlusion. Then we've got, so anterior spinal artery supplies the medulla. That's bad. That's actually very bad. Because the medulla and the pons have higher centers for cardiovascular control. So you might see contralateral hemiplegia, deviation of the tongue, dysphagia, nystagmus. You're getting the theme, I'm hoping. Vertebral artery, lateral aspects of the low medulla, including accessory nuclei, and you may have dysphagia. And so all of those, I'd urge you to go ahead and make a chart. You're going to see common signs and symptoms across the board. Lindy Ekman's got a great chart, although it's very large, so you might want to reproduce that. Concept map some things, compare and contrast. So do your posterior cerebral artery, your vertebral basilar artery kind of in the middle, and then go off and compare and contrast each one of these syndromes to start to learn it with the concept mapping. I am available if you want to sit down and really go through it of how to study, but some of this is going to fall back on you, unfortunately, because some of it is really review from last summer. So if you have any questions, let me know. This might overwhelm you, especially if you're listening while not following along with the PowerPoint, so you may want to go back and take some notes. All right, guys. Thanks for not coming to class so that I can be out of town, but I will see you when I get back. Thanks.